So welcome everybody, and thanks for being so flexible with Dr. Withy's travels and Charnel and I trying to manage the sessions while she's away. She'll be hopefully back next week. Charnel, I'm getting a request to admit, and so should I continue to?
Yes, go ahead and I'll take care of all the, I'll manage the waiting room.
Oh, okay, got it. All right. So a lot of us have been, we're very fortunate to hear Dr. Wee's presentation last week. And it brought up so many urgencies as she was speaking with us that our community is struggling with, and that is referral for pediatric mental health services. And I just wanted to remind the group, as she was talking about the number of positive screening she's experiencing just in her own office for pediatric mood disorders and anxiety disorders. And then looking and struggling, as many people in the community are, is finding a referral resource for those families and for those patients. And I just wanted to remind everybody that our colleagues at the Department of Health, Child and Adolescent Mental Health Division, we were told as a meeting last week from their directors is that they are open for referrals for care, and that you in your clinics can help the families register for CAMHD services. And they can actually, and this is something we've done at the emergency room and the family treatment center, and whether it's the wee hours of the morning, is while you have the families there, you can do the application, online application for Child and Adolescent Mental Health Division services. And then you could have the parents sign the consents form with you right there in the clinic or in the office. And then you can actually assist them in sending that registration in with the consents. And we've been very successful for CAMHD to review those applications and then quickly mobilize their teams to provide either remote services or in-home services. And I think we're seeing a shift in the pandemic with the COVID numbers. We're slowly seeing them kind of probably increasing. I'm sure you've been following that. So we're seeing the COVID numbers going up again, but I think CAMHD is providing a much more school-based and home-based face-to-face services. And we'll talk a little bit about how we integrate treatment teams and school-based teams with pediatric onset OCD. I did want to also mention that even though we're seeing many of the safety mandates for COVID being relaxed and removed, we still have the children in our schools with distance separation between them. They're wearing their face masks. And also we have a national emergency for children's mental health in this country. And that's been identified by a number of agencies and groups like the American Academy of Pediatrics, but it's also discussed in the president's office. And that's an initiative that it's very important for the administration to continue to support. So many, many months beyond COVID or whatever it changes and whatever it looks like for us, the initiatives and the efforts for child and adolescent mental health services will continue. So today, yes.
Quick question. So for the CAMHD services, can you repeat one more time how everyone that's listening can get more information or register for their services?
Great, and that maybe that's probably an indicator for me and you and Dr. Withy to ask Dr. Humphrey to return and provide an update in his CAMHD presentation and services. But what I do want to say for the folks who are on the call today, CAMHD, and what we can do is put that in the resources or email that to the group later, but they have an online application form, and we can send that online site to you where you can actually pull it up and assist the families in registering for CAMHD services. And remember, this is the Department of Health, and so they're looking at families who are part of the Medicaid carve-out under the Quest plans. And so this is really important because of the Quest plans. Many of the community providers don't accept some of the Quest plans. And so that puts a lot of limitations for us.
And as a quick pediatric echo plug, so we're working with CAMHD to do an updated presentation post-COVID for all of their resources, since there have been so many changes. That's in the near future. If not this month, they'll be presenting next month. So if you're not signed up for the pediatric echo that we do every first and third Wednesday, go ahead and sign up at hawaiiecho.info. And I'm looking right now for CAMHD info, so I'll put that link in this chat here while you're going through your OCD presentation.
Okay, great. Thanks, Shorna. So what I'm going to do is just to start the OCD presentation. This is from our colleagues at the University of Washington, part of the Montana Access for Pediatric Psychiatry Network. And this was presented in February, and Dr. Urata provided this presentation. And I'm going to go through it in whole and do the best I can. And I also have some additional resources as we go. And let me just try this. And some of the objectives we'll talk about today. So I want to address your questions as they come. And Charnel, thanks so much for managing the chat. We're going to look at some of the diagnostic criteria from the DSM-5. As you all maybe are aware, the text revision DSM-5 came out just recently, and it's maybe 12 years. It was 2013. So yeah, about 10 years since the DSM-5 came out. We'll look at differential diagnosis, comorbidities, definitely the ones you want to be thinking about when you're looking with or working with the family and the youth in your office. And we'll look at some diagnostic tools used for assessments, not only for the youth, but also the engagement of the family in some of the symptomatology that the youth is experiencing at home. So what kind of accommodations or engaging is the family in providing a negative reinforcement for the youth? And that's part of the treatment plan that we'll be talking about with exposure and response prevention as part of the CBT, or the cognitive behavioral therapy. We'll look at a little bit at the neurobiology. The neurobiology is, there's a lot, it's a packed picture. However, I think more and more is known about the neurological basis of anxiety and the drivers of anxiety, and also what CBT has shown to do to the neurobiology, and what's evidence from MRI studies, as well as the use of medications. And then we'll look at treatment, both the CBT and the use of medications for children. Oops, sorry. Let me just, okay. So the diagnostic criteria for obsessive compulsive disorder, this is from the DSM-5. And the obsessions are described as recurrent and persistent thoughts, urges, or images that the child describes as intrusive. I'm going to be talking about pediatric, but you can also translate this into your adult patients also. And then there's attempts to ignore or suppress or trying to neutralize those obsessional experiences, often causing quite a bit of distress. The compulsions are the actual behavioral repetitive experiences, such as hand washing and ordering or checking, even mental acts such as counting or praying, repeating words, are usually driven because of the obsessional experiences and behaviors or mental acts to prevent or reduce the anxiety or the distress that the patient is experiencing from those obsessional experiences. The minimal criteria is experiencing obsessions or compulsions that are part of the behavior for more than 1 hour a day, and that it causes significant distress or impairment in occupational important areas of functioning. And for children, it's engaging with families, engaging at school, engaging with their friends, extracurricular activities, all the things that the kids are normally involved in. The symptoms of OCD can impair their involvement in those things. Okay, and epidemiology and risk factors, I think we're looking at maybe 2 to 3% prevalence across for children. Even though they say the average age of onset is like 19 to 20 here, I think 50% of the cases in the recent data, the literature base, has maybe more than 50% of those cases all occurring during childhood. And maybe the boys having more experiences below the ages of 10. And by the time you get to middle adolescence or later adolescence, you have more of the females involved. Some of the risk factors are based on studies looking at genetic twins and family studies. There is a high heritability component of this. And so many times when you talk more about siblings and cousins and family members sharing those experiences or symptoms, you'll find a strong hereditary component for this for other family members. It also relates to if you're ever thinking of using the medications, you also want to know and get a detailed family history of medications that may have worked for other family members, maybe the first line medication you want to try for your patient. There's also the infectious etiology and the autoimmune etiologies of obsessive and compulsive disorder. And that includes the PANDAS and the PANS. And the PANDAS is the pediatric autoimmune neuropsychiatric disorder associated with the group A streptococcus infection. And the PANS is the pediatric acute neuropsychiatric syndrome. And these are, very rapid onset. Usually there's an infectious or an autoimmune etiology. But those are also considered part of the risk factors. We're also going to have one of our child fellows present in June on his work in pediatric PANDAS. And also there's risk during premenstrual experiences when there's hormonal fluctuations, peripartum, postpartum, trauma, neurological lesions that may be a sequelae of stroke or traumatic brain TBI or a traumatic brain injury. This is pretty important too, because we have a lot of kids who have who've experienced concussions, and we try to prevent those concussions by getting them out of contact sports. But sometimes the kids will experience significant post-sequelae of depressive anxiety symptoms after their post-concussive experience. There's a lot of work involved in right now looking at concussions and traumatic brain illness and the role of TMS, trying to help those children. We'll talk a little bit about that later. We're also going to have Dr. Ona later in the summer talk to us about updates on transcranial magnetic stimulation. Okay. All right, some of the differential diagnoses to be thinking about when you're evaluating youth for obsessive compulsive disorder. You want to be thinking about body dysmorphic disorder, other like hoarding disorder, or trichotillomania, which is the urges to pull the hair, or the skin picking, excoriation. There's also substance-induced OCD for a lot of our kids involved in with methamphetamine use or cocaine use. We see sometimes the sequelae of OCD from that. It's important to rule out stereotypic repetitive movements of those children with neurodevelopmental disorders or disabilities such as autism spectrum disorder. There's a note here about COVID-19, and I'm seeing quite a bit of specialty clinics across the country addressing the exacerbation of not only mood symptoms, depression, also anxiety from COVID, but also the exacerbation of OCD and how many times the therapeutic approach has to take into account the relevance of the pandemic into the family's lives, especially for those children who are experiencing contamination obsessions and also contamination compulsions. Okay, so those children who are diagnosed earlier, like we talked about, about 50% of those diagnosed with OCD will have a youth onset, and the earlier the onset increases the risk of comorbid ADHD or tic disorders. They share a genetic a relationship, and those diagnosed later on are associated more with mood and psychotic disorders. The bars on this section over here kind of organize the things you want to look at or to evaluate in your assessment of anxiety or OCD for your youth and family. And you want to make sure that these comorbidities, such as substance use disorders in the orange, the impulse control disorders such as ADHD, conduct and oppositional in the blue, other mood disorders, major depression, bipolar disorder, dysthymia, and also the constellation of anxiety disorders below are also investigated, because you'll have to consider addressing each of those if they are co-associated with OCD. And this is a slide looking at the difference between the anxiety disorder OCD versus the cluster 2 personality disorder, which is associated with avoidant or dependent or anxious presentations, and that's obsessive compulsive personality disorder. And pretty much the focus here that with obsessive compulsive disorder, you really are looking at the unwanted thoughts and urges are because of profound distress and anxiety. Those symptoms, especially in youth, can change, and that's important when you're using your diagnostic assessment tools, that you do it frequently so that you can capture the variance in the hierarchy of presentation, as well as the intensity of those experiences. And those are addressed in the CBT, which we'll talk about in a little bit. So when making the diagnosis, usually a quick screen, the instrument, the diagnostic instrument tool that we use to try to capture the hierarchy of obsessions and compulsions, we'll talk about in a second. But this is just a quick 6-question screen that people use just to identify if you think that there might be OCD that needs to be investigated further. And so, like, do you ever have unwanted thoughts that upset you and that you cannot suppress? And do you have worries that just won't go away? Do you ever have ideas, images, or urges that make you very anxious or uncomfortable? Do you have to do rituals over and over again, even though you know that it doesn't make sense? And do you do things or have habits that you don't want to do because you feel anxious or worried about something? And do you do things that you just can't stop? And usually that's enough to screen for positive. And some of the challenges for with children, working with children, is they do have, sometimes it's a challenge to articulate what they do, to describe their obsessional thoughts or images or impulses, and as well as for having them trying to describe to you what they're doing for their compulsive behaviors. The earlier the onset, they kind of is associated with longer duration of the illness. And also, when we'll talk a little bit about refractory treatment and the role of intensive outpatient services as well as residential services. Intensive outpatient services, what we have here at Queens or Kahi Mohala, is where the youth is involved in day treatment services for their therapy, and then they go home at night. Residential is where they're involved in either community-based or hospital-based programming for their treatment, and that's an out-of-home placement. For the benefits and regarding working with kids, it's important to, when working with a child, you want to make your assessment with the guardian or the parent, and then also it's important to include the teacher. I think all of last year, the last couple of years, we were doing more virtual school, but in the last year, the kids had gone back to school since August, and many of the kids are having transition challenges, which only exacerbate their symptoms. But it's important to get a sense from the teachers what they observe, because it's also going to be important to include them and as allies into the treatment team, because the youth is going to be at school and they're going to be needing coaching both at home or at school. And the teachers can actually be part of the coaching team. And then again, pediatric onset has a better prognosis than the adult onset. And so I think using the obsessive compulsive scale, this is the children's Yale Brown, and we've been using this for a long time. It's a 10-item scale. It actually looks both at the obsessions and the compulsions, but then it also organizes it into a hierarchy of intensity and the level of distress that is causing not only the youth, but also the family and the functional impairment. And then it has ratings. So it could be subclinical, mild, moderate, and to extreme. And what I'm going to just show you is why I like the Y box is because it has a lot of the obsessions listed as in current or past, because you kind of want to know if it ever existed before. And then you kind of want to get a sense of in the other. So each of these areas I've said, such as contamination obsessions, sexual obsessions, superstitions, and magical thoughts. And let me just get down here. Under the aggressive obsessions and the religious ones, they'll all have this other that you can describe if it's not captured here. And then you go ahead and you list all the obsessions, and you put number 1 as the most intense or overwhelming, or the one that causes the most distress. And you go just down the list to like 4, which is the one with the least amount of distress. And that's the obsessions. And then you have the compulsions, which is another list of the washing and cleaning, the hoarding, the superstitious ones, the rituals, and also the ones involving family. And then again, you make your list of those that are most intense or most severe, causing the most distress. The ones that the children describe as having least amount of control as number 1, and then you just march your way down to number 4, which is the one that's probably the least amount of distress. And your treatment is going to be aiming at number 4, and then you'll move up the hierarchy. And then for each of the obsessions and the compulsions, you then go ahead you can work with the family and the youth together, and you can identify the time amount each day that the child is occupied in the obsessions, the interference it causes in their normal routines and activities, and the distress that it causes. And the same for the compulsions, and then you can get your rating scale. And this is available online. We'll also have this in our resources from this presentation that you can have access to. The other thing I was going to show you, and that is this one here. This is the family accommodation scale. And this is the one that actually catalogs the amount of engagement the family has with the youth to provide a kind of a negative reinforcement to the symptoms. That means, how are they engaged? How are they allowing the youth to complete their compulsions? Are they going out of their way to help the youth? Things like that. And then the treatment is really to organize these around parent teaching, parent training to become coaches. Because when they work with the therapist, it's just usually for maybe 1 hour a week or 1 hour several times a week. But usually they go home and they practice the mastery and the skill set with the family as a coach for the mastery. And then that also translates into school. Who amongst the school teaching staff can work with the youth to help them in mastering those stressors and those obsessions and compulsions while they're at school. All right, and we'll keep going. And let's go. So this is, and I kind of had mentioned that this brain circuit is a little messy. This is the cortical striatal thalamic circuit, and I'll do my best just to make it as simple as possible. So you have the areas of the the brain, and there's the cortical parts and then the subcortical parts. And so the area like of the amygdala is this kind of the center of anxious experiences, and but also the areas of the basal ganglia in the striatums, that's the caudate and putamen and globus pallidus. These are the sources of anxious drive, are kind of driving the anxieties into the frontal cortex, which is pretty much possibly, hypoactive, and it's the seat of control. It's probably the area where it puts the brakes on things, and we call that the prefrontal cortex is the area of executive function. It's the area of processing speed. It's the area where working memory is. And sometimes those areas are hypo-functioning, are hypoactive. And the CBT and the medication usually work on these centers to give them a greater ability to provide a braking function on anxiety. One thing interesting about the MRI studies with children with OCD, whether they're receiving just CBT alone or medications or the combination of both, when compared to those children who do not have OCD, after treatment, the brains of those children with OCD start looking like the brains of the children without OCD. So with just CBT or medication, you can actually see the brain changes, and they measure that by functional MRI and the area of blood circulation in the brain, and oxygen utilization, and the integration of the multiple circuits. And for treatment, we'll talk a little bit about both using CBT and the SSRIs. And this is where I'm going to just pause and run a 2-minute video right here. See if I can get that.
The most effective treatment for, in what I have found, is the cognitive behavioral therapy, very particularly exposure response prevention, often referred to as ERP. And that's a treatment, the cognitive behavioral therapy really focuses on cognition of thoughts, behaviors and feelings, and how they kind of play together and affect each other. And that's often used for depression. You kind of break it apart and help people deal with challenging thoughts and engage in behavior activation. When you treat anxiety, such as and OCD is a big part has an anxiety presentation, you really help people figure out kind of what they're afraid of, what really triggers that. You teach them about kind of responses that they will have to the fear, potentially figuring out what triggers their fear, and you create kind of a map, what you call a hierarchy, from the thing that they fear the most to kind of medium, even a low fear. And then slowly but surely through educating them, we move up that hierarchy and help patient build mastery. Moving up that hierarchy, we call that exposure. We expose a person with, she or he really figure out what they're afraid of, and they expose themselves to what they fear. And then the trick is then they don't do the response. They don't wash their hands, they don't check, they don't do the things that used to kind of reinforce the fear. And over time, this builds mastery. They get used to it. We call that habituation. And that is probably the most effective treatment for OCD and for other anxiety disorders. There are other treatment modalities that are effective, such as medication, and there are newer ways of thinking about exposure, implementing exposures. There are debates about how important habituation is or is not, but the vast majority of research indicate that exposure and response prevention with habituation is the most effective.
So if I can say his name, Dr. Bajor Vincent is the director at the Harvard's program for mood and anxiety disorders. And this International OCD Foundation is a great resource for families, for educators, for therapists who are working with the families and looking at manualized CBT programs, also video content that's been extremely helpful. So I try to kind of guide families to get these resources also. So let me go back. And so just to go over some of the treatment, I wanted to do the video first, and it's because Dr. Bajor Vincent also identifies kind of the terminology of habituation, identifying symptoms and developing a hierarchy of symptoms. Many times children can't describe the symptoms or the intensity of their experiences. So we use a fear thermometer, and a fear thermometer is just a kind of a regular thermometer that's colored, and we let the children kind of color it themselves. And they kind of march up the thermometer and tell us how intense they're experiencing those obsessional thoughts. And then you kind of want to match the list of obsessions and compulsions with each of the fear thermometers, and then kind of help the hierarchy of like 1 through 4 on that the diagnostic CY box. And then you start with level 4, or there might be even more. So you start at the very bottom and help the family, the youth, and even teachers at school help the youth develop mastery and skills, because they're going to practice on their own and with their coaching teams throughout the week. And then they'll go back and assess therapist during each visit. And one thing about youth, though, and with kids, is sometimes the focus of treatment shifts, because there's some variance in when they may be experiencing different types of obsessions and different types of compulsive rituals, and those can change over time. And it's important that you make sure that the families can also sense the change with you and work with the youth together, and also helping the teachers at school. So some of the early studies called the POT study, or the Pediatric OCD Treatment Study, was published first time in 2002. And it really looked at the combination of CBT, cognitive behavioral therapy, where you do exposure and response prevention, and also the addition of an SSRI or sertraline, Zoloft commonly known. And the combination of CBT and sertraline together were statistically superior to all the other groups. And the groups included those that had CBT alone, just the medication alone, the combination, and then also placebo. And then they usually recommend that for mild OCD, you start with CBT. And we here at the Department of Psychiatry, for children, we engage CBT right away. I mean, that is first line treatment. I think the effect size is incredible. And then again, you're also, some of the criteria that you would consider using an SSRI are down here. So for CBT, you want to make sure that the family's engaged with CBT, you've got active families involved with youth, and you may or may not have active teaching staff. You're also, when we start CBT, we're also thinking that medication may be needed down the road or even immediately, depending on how severe it is, the OCD. But you also want to assess the family that there's no contraindication for the use of an SSRI like sertraline. So if there's a family history of bipolar disorder, or if the youth has had bipolar disorder, you probably do not want to go with an SSRI right away. You want to maximize CBT. Many times CBT is not available in the community, and so you're going with medications first. Oops, sorry. CBT usually is maybe 10 to 20 sessions. It's individual and also with groups if needed. The intensive outpatient programs and the residential programs definitely incorporate the use of groups. The use of Zoom during the pandemic has also been shown to be very helpful, that you don't have to have face-to-face engagement with the therapist. But again, using the Zoom for the therapy is to engage the family and the youth into developing teams, and the family as a coaching team. The use of SSRIs, they recommend using first line for, especially for children, is sertraline or an SSRI. It's probably has the most strongest indication for anxiety disorders and OCD. You want to be thinking about titrating the dose as quickly as tolerable, as quickly as the youth can tolerate. And also you want to do a minimum of 6 to 8 weeks. We tend to try to push it to 8 weeks for optimal efficacy. But also within the first few days is, of course, when you're spending a lot of time with the youth and the family talking about potential side effects that are occurring. And you're also in the consent process, informed consent, you're talking about the emergence of those side effects, especially the black box warning ahead of time. And so that there are no surprises, and that the youth and the family can go to you for any questions. And let me just do this here. Okay, and then so this second one is kind of more discussion of SSRIs. Again, Alicata trial, 8 to 10 weeks. We push it usually to 12 weeks. Also, with the SSRIs, the other SSRIs we use, is if the first line is maybe sertraline, if they can tolerate it. If a family member has had a trial of a medication that has been very beneficial for them, or if the youth has had medication in the past, we tend to go with that first line. The other SSRIs that are indicated for OCD at higher doses, of course, are fluoxetine or Prozac, and escitalopram or Lexapro. And again, when we talk about higher doses, it's not uncommon that you're pushing the dose to 200 milligrams for sertraline, 60 milligrams, sometimes 80 milligrams for Prozac, and for Lexapro or escitalopram, you can't go beyond 20 milligrams. But again, you are thinking about every 1 to 2 weeks, you're increasing the dose during the titration phase. SNRIs that have some clinical indication or evidence base for the treatment of OCD are Effexor or venlafaxine. Those are the only ones, though we see Cymbalta or duloxetine indicated for children with anxiety disorders. Cymbalta or duloxetine doesn't have an indication for OCD. We tend not to augment SSRIs with a tricyclic like clomipramine, but again, if the youth doesn't respond to any of the SSRIs or fluvoxamine, which is another SSRI, treatment refractory, you have to at least have a trial of clomipramine. We don't tend to do this very often because the kids usually will respond to CBT and an SSRI. But again, because of the tricyclic antidepressant, you have the cardiac risk factors as well as the risk of suicide attempts. All right. And we do augment, though, when we've optimized the maximum dose of an SSRI, we will use a small dose of an antipsychotic sometimes, which has been shown to be very, very helpful. This is off-label, and so risperidone or aripiprazole. Risperidone is Risperdal, or aripiprazole is Abilify at very low doses, has been shown to be pretty helpful. Okay. And then the CBT, the exposure and response prevention. So for the kids, it's usually, you're looking at 10 to 20 weeks of weekly treatment with a therapist and weekly daily practicing with your family and school staff, but you're exposing them and getting them the mastery to experience the exposure to the stressor, but you're not following through with the compulsion. And that's where habituation occurs. As the child gains mastery over response prevention, then habituation starts to increase, and they find that mastery. And so those urges to complete those compulsions slowly decrease, and then they go away. Which is quite remarkable when the kids experience this. I don't know, for maybe you all personally during mindfulness or deep breathing or square breathing, when you have anxieties or fears and you do your breathing exercises, it's almost immediate how fast the body can respond. This is similar to OCD. Which is remarkable is that there's almost an 85% response rate just to CBT alone. And again, those who are refractory do also consider intensive outpatient programming or residential programming. The study with clomipramine was a tricyclic antidepressant, similar to the sertraline study that we talked about, occurred in 2005. Again, clomipramine was shown to be very effective in combination with CBT. And I do want to say one thing about neuromodulation. And what we know for the adult studies is transcranial magnetic stimulation has the FDA indication for refractory depression and refractory OCD in adults. And that indication from the FDA came for OCD in 2018. And those studies then have driven NIH, the National Institute of Health, to look at the role of TMS for refractory depression in youth. And the National Institute of Health has now sponsored for possibly the last 5 to 8 years, multiple sites across the country. And the leader of that is we have colleagues at Mayo Clinic. They're pretty much orchestrating all of the modes of national studies in working with children with refractory depression and TMS, shown and have just excellent data in regards to not only efficacy, but tolerability. And especially for those children who have refractory symptoms of, say, depression, but also can't tolerate multiple trials of medications because of the side effects, TMS is, I believe, close. Within the next few years, we'll have a federal FDA indication for TMS for refractory depression for our kids. Dr. Ona has been involved in TMS in working with a pilot program with kids in this community, and where she's had to work really hard to get IRB approval and FDA approval to do that work. She will also share her experiences later on in the summer. I do want to say one thing about TMS, and that is the National Institute of Health has sponsored many studies looking at the role of TMS in other indications with youth. and that is looking at traumatic brain injury, helping those youth who are experiencing inattention and impulsivity because of brain injury, and using TMS to help provide that treatment. There also, which is really interesting, is just last week, National Public Radio talked about the use of EEG, or electroencephalography guided TMS, in the use of adults and children. Those studies are being done right now, where you're looking at the EEG guiding you where the TMS is located in the frontal cortex, in looking at various sites, but also using the energy to provide those currents at a lower voltage. And so you're not needing the higher voltages that some of the original studies were done. And what I've noted when I've been working with Dr. Ona, and that is sometimes the energy used to provide TMS can be sometimes uncomfortable, like a woodpecker pecking on your scalp, and you have to kind of adjust that to make it tolerable. Well, kids definitely don't tolerate the woodpecker, and so we're seeing that you can use energies quite a bit less than what's indicated, and those studies are very exciting. All right, so let's see, what else do I have? So this is my last slide. So let me just quickly go to kind of a summary. Let's see here. Let's see, I have to go here. There it is, but I can't see anything. I'm just gonna leave it like that so I can see it. So our kind of the summary is that obsessive compulsive disorder, we're seeing more 2 to 3% of the children and adolescents, and it frequently underdiagnosed and undertreated because of the hidden nature of the symptoms. So that's why it's really, really important to do the preliminary screening in your offices. And then if you're definitely feeling that using a diagnostic instrument like the CY box is warranted, that would be very important. Many of the kids have already engaged their family and kind of entangled them in the child's rituals. So a lot of work will have to be involved in family education, in training the family to be coaches. Most often, OCD in children is accompanied by, and what we saw in a previous slide, the comorbid psychopathology. And as we saw, substance use disorders, especially with our older, our teenagers. Substance use disorders, other impulse control disorders, including, the ADHD, obsessive conduct disorder, other things like that have to be ruled out, including depressive disorders and the other constellation of anxiety disorders. Simple probes for the presence of anxiety or worries will identify most of the kids with OCD. And of course, working with children, you have to spend a lot of time gathering information from the parents as well as from teachers. And sometimes I'm finding out that sometimes the parents aren't, and the teachers don't quite communicate what the child is doing regarding rituals at school. And many times the teachers try to accommodate for the youth to be able to do their rituals in isolation or to go elsewhere. But it really is important to engage the school with the family to provide comprehensive service for the youth. And I think that's really where the power of the efficacy of CBT comes in, is when you have everybody around that youth involved with the same focus and treatment goals. Assessment should include standardized quantitative measurements of symptoms, as well as the inventory of target symptoms. And that's where the CY box comes in, where you actually target your hierarchy of symptomatology, and you work with those that are least distressful, and you go up the hierarchy scale to those that are most distressful. CBT is the treatment of choice for moderate and mild cases. Medications are reserved for the cases of OCD that are more severe, have multiple comorbid conditions, and are accompanied by poor insight and maybe CBT resistant. Also, you may be thinking medications first line if it's in a rural community where CBD resources are not available. We're finding that in rural Hawaii with the use of Zoom, it's a little bit easier to engage therapeutic resources for families, which has been one of the blessings of the pandemic. SSRIs are the first line recommended medications for OCD at any age. And let me just pause it there. Charnel, do we have any questions or comments? And I did promise everybody that we would get the resources for CAMHD available to them.
Okay. Yes. So Dr. Cohn asked, I don't know if you did answer his question already, any idea what the cure or response rates are for those treatments? And then the second question was from Ella. Are they ever able to wean the meds or get them off of them? Or is this a lifetime of things?
Yeah, great question. So we'll go Ella first and I'll work back to Dr. Cohn. So we tend to, when we use CBT for youth and medications, we target treatment outcomes for the kind of the remission of symptoms for about a year in duration. And then we start looking at keeping the teams engaged and then tapering off the medication. And when we talked about titrating on the medication every 1 to 2 weeks, we'll probably take the same amount of time to taper them off the medication. But making sure that CBT is engaged, and if they're no longer in therapy, that the youth and the family are mastering those skills so they can describe those skill sets that they use. And again, then that's the only way that we'll start tapering off the medication. So for the most severe cases, possibly a long period of medications. For those more moderate, not so much. After a year, we're taking those medicines off. Dr. Cohn had talked about the efficacy. CBT, I think, demonstrated about a effect size of about 0.8 alone. So about, but again, with CBT and medication, we're looking at superior to controls, and that effect size was more closer to 0.9 or 1.